Terry Thompson from the University of Dayton, editor of the journal Health Communication. And I have two topics that I'm hoping we'll be able to cover today. The first one I've got up on the board, and it relates to some work that I'm doing with the World Health Organization, and I'm really excited about it. I thought you might find it interesting, and then I hope to move on to a discussion of health campaigns after that. If we don't finish all of that today, I can pass that on to you later. But let me give you a little bit of history first about this. You all know there have been a lot of crises, health crises, in our world recently. Well, you also all know that the World Health Organization plays a primary role in dealing with these crises. They have never had any empirically based guidelines on which to use. You're not surprised to hear that, are you? You must have worked with them before. But they never had any empirically based guidelines on which to base their dealings with, their reactions to these crises. So especially lately with MERS and Ebola and SARS and various national disasters, they realized that this is a real problem. Last summer, in June, they brought together a 25-person panel from around the world. A 25-person expert panel. I say expert in quotes since I put myself in that group, and that doesn't sound very humble, but boy, was it a fascinating experience. There was one person from Singapore. There were only two from the U.S. There were people from numerous Middle Eastern, Spanish-speaking, and African, of course, countries. So several people from the various ministries of health, people from Doctors Without Borders. Oh, speaking of which, did you hear about the bombing? Oh, it's so upsetting.
MSF.
I'm sorry?
The MSF bombing.
Is that where it was? I just read about it very quickly. Of the hospital?
Yeah.
Doctors Without Borders, a hospital. Thank you for remembering that location. So, anyway, American Red Cross, no, not the American Red Cross, the World Red Cross. Anyway, fascinating group of people. So they brought us together in June in Geneva to try to begin probably a year-long process of generating guidelines based on something more than this is what worked for us here, which is what they've usually done in the past. So I thought you might be interested in hearing a bit about that, those parts that I am able to talk about, because of course for some things I was sworn to secrecy. But it was really one of the most interesting experiences that I have had as a health communication person, to have all this shared expertise. There were some other academics, and they're mostly medical sociologists, one right there in Geneva. So anyway, so it was quite interesting. So, yes, go ahead.
Good. That was a question.
Oh, okay, very good, very good. Well, I'm glad I was ready for. So, yeah, social scientists, physicians, nurses, allied health providers, people with campaign design experience, and campaign implementers, health public relations practitioners. We had people from the BBC Foundation that funds much health communication research. Boy, she was especially interesting. Various public health scholars, of course, and policy developers, implementers. Now, for people like us in academia, that's an especially important contribution, because policy developers frequently don't base policy on any thing that we would regard as highly credible. They tend to be selective about the people that they bring in as they're making decisions, etc. So the inclusion of policy developers and much talk about how to further include policy developers and community members was something that was especially interesting to me. All right, I've hit the wrong button. I probably turned something off. Okay, there we go. There. So the two basic kinds of health crises that they are interested in looking at are, of course, the various illnesses and epidemics, which we have seen so much of, as well as the natural disasters. We all know from the data that these natural disasters are becoming more frequent with climate change. We can see here with the haze, much worse than it, from what I understand, it typically tends to be that climate change is real, and I suspect that the only people who probably deny that are conservative American politicians. That's my perception.
From the South.
Oh, yes, that's it, from the South. Exactly. Somehow they can't see that, but you don't want me to say too much about that. I'll go ranting on about Fox News, and that will get us off a topic. So, various natural disasters. Now, as we look at illnesses and epidemics, we know that, of course, that historically many were plagues of various kinds, and we had great difficulty controlling this. I say we, like I was there, but I'm not that old. The development of our understanding of germ theory and hygiene substantially impacted these. Of course, next notable development was vaccination, until we ran into some, what would be the best word to use? A wrench thrown in the works with some of our understanding, not our understanding of vaccination, but public understanding of vaccination. I know a waitress at a restaurant that I go to that's and I have several friends, continue to refuse to get their kids vaccinated on the basis of that one study that we know was so badly flawed, that where the data were completely made up, that's been, that's been well established. And no matter how many times I tell them that, I have no impact on them. So I don't know how much impact it's had in Singapore. Perhaps you can tell me. In the U.S., it's had quite a bit of.
And Canada too.
In Canada too, you said. Yes, yeah, that's good. How about in Singapore?
There's no discussion. I mean, you're required.
Right.
You can't get, with the kids now, you can't get them in school if they don't have the letter from the hospital, so there is no debate whatsoever.
What a reasonable way to handle it.
The policy, right? And going back to the discussion of policy,
yes.
because of.
But so is the case in US and Canada. Public schools, you cannot enter without vaccination. Mm-hmm. However, then kids just go do homeschooling.
Yes, yes. Homeschooling has become very popular in the U.S. Mm-hmm. Yes, I'm in a what's called a house church group with a bunch of people who homeschool their kids, and it's fascinating. Does anybody here homeschool their kids?
Yes, I've got friends who do homeschooling, but it's quite difficult. Like, you have to match their curriculum.
I see.
And eventually they have to go and take PSLE and still.
Well, it's become much easier in the U.S. and in Canada too. So many of these people do home a school, and then when they show up for our house church meeting at night, they don't want anything to do with the kids. They would just want to let the kids run wild. And so it's been quite striking for me. But in the U.S., kids who are not getting vaccinated, you probably heard about the Disney world problem. Unvaccinated kid comes in, gets measles, and then gives it to kids who are too young to have been vaccinated. So it's been quite a problem for us. I would be, in general, no, I guess I don't know that I'm in favor of states' rights. I'm definitely in favor of federalism because states make stupid decisions. But I would be much more comfortable with the mandate that all kids have to be vaccinated. Anyway, so we know the problems that this has led to. So the recurrence of some formerly eradicated
There's one more issue of vaccination which is occurring, let's say in South Asia, for example, in particular in relation to tuberculosis, is resistance to vaccination or resistance to medication.
Interesting.
Because of the bad follow-up of
Right.
how the medication is taken,
Exactly.
the gaps in the treatment, and that creates resistance.
Wow.
And
Now
that's a much bigger issue of antibiotics and full dose of.
And fortunately, there are some really good scholars studying that and studying how to address that. Tanya Berry has done some very good work on that. But you're right, that's even a bigger issue for us in the States, too. So we also know that almost all recent epidemics have spread to humans from animals. We really first discovered this with AIDS, but we found this as a continuing problem. So, some notable recent epidemics: HIV, SARS, various influenzas. I've just put the popular names up there: Ebola, MERS, etc. So, issues with which you are all familiar. And breaking this down, some key issues that we all need to deal with as we think about these things, the epidemiology of this. We had an epidemiologist in the group yesterday. Oh, we still do. He's just on the other side of the table. Good. So the import of understanding the epidemiology of this, diagnosis, treatment, spread, contamination, quarantine, and communication. I have to give you a little side story about why I decided to participate on this expert panel. Not anything for which I get compensated. The World Health Organization gets money from the UN. They can't go paying alleged experts to come in, etc. So I got the invitation, and by this point I was already completely overwhelmed with the journal, having gone to 12 issues a year, barely keeping my head above water. I was getting ready to take a group of students to Rome for a summer study abroad program, and take a group of students somewhere, you never know what crises you're going to encounter. Fortunately, I had no crises this summer. I had no burst appendix. I had no one get arrested. I had no one discover that they were pregnant. I know, really. But when you're dealing with students, I bet they're more well-behaved in Singapore. But all right. Well, these are U.S. Students. But anyway, so I was completely overwhelmed. I got this email from World Health Organization. I thought, oh, gosh, this would be fabulous. I would love to do this, but I just don't know how I could fit it in. So that was maybe on a Monday or a Tuesday. And then my ex-husband was once again hanging around my house that night. He has, over the years, loaned me money, so I could take my mother and my younger brother, who's severely disabled. Some of you heard about him yesterday, to my daughter's wedding, and it cost a fortune, and I couldn't cover it. And anyway, he paid for it. So I kind of, as repayment, have to let him watch my television set time. It's very strange, very strange. But at least he generally has good taste in TV, so he turned on PBS's Frontline. Are you familiar with that show? Documentaries. This one was on Ebola. Have you seen that one? James, I see you nodding your head. You probably know the quality of the work that they, so anyway, this one was on Ebola, and the theme was how the spread of Ebola was directly related to the lack of communication amongst the experts about that. It was like God saying, yeah, you think you're not going to go, huh? I'm going to give you a little additional input. By the end of that show, I decided, all right, I'm going to go, which was such a good decision. I hope that all of us as a group can have an impact on some of these things. And as those of you who heard me rant on yesterday know, I think really having an impact is what it's all about for us. We do all of this research and it doesn't do any good unless we can have an impact. So that's just a side a story. Convinced me that I had to get involved. I was telling someone, oh, I know, it was my sister's first ex-husband. We keep in touch in our family. My sister's first ex-husband was not a good husband, but he's a great ex-husband. He's a great ex-husband. So I was talking to him on the phone. I was telling him about this, and I said, "Can you imagine that Lou, who's my ex, that his television viewing habits could have a positive impact on me?" And he said, it's an expression you may have heard before. Even a stopped clock is correct 2 times a day. I just loved that. Yes. I did not share that with my ex, because I don't think he would find it quite as entertaining as I do. So anyway, so some key issues for us to think about. Now, we also know, again, the increasing frequency of natural disasters. I don't think it's just that I'm paying more attention to them than I used to, although that is true, that I am paying more attention to them than I used to. But the data do seem to indicate greater and greater frequency. Now, we know these things go in cycles, etc. But a lot of things for us as people who deal with health-related issues and recovery from them need to deal with. So here we have a tsunami. You probably recognized that. Damage from an earthquake here, volcano. Do you have many natural disasters besides haze? And very hot and humid temperatures here in Singapore? I've never heard about many. So you're kind of sheltered from.
They tend to be in the periphery. Indonesia, it's got many volcanoes and been recent eruptions and.
All right.
As well, Philippines. Yeah.
Very good. Yeah. Thank you. Okay, so the World Health Organization group is starting with this working definition of risk communication. And risk communicate. Yeah, go ahead.
No, so just a question. Why haven't you included lifestyle diseases in the list? Or that was not a mandate of the panel?
That was not a mandate of the panel. Certainly important issue.
But as you start getting into risk communication,
Yep.
that's where the real work has happened.
Very much, yes. So risk communication is related to many health behaviors, and the World Health Organization is not focusing at this point on all of those. Now, certainly in some of their other work, of course, they do. And they've contacted me over the years about a publication of some of the work that they do, but they're generally so busy dealing with crises that they don't have time to write it up, or even to really well document the impact of their work. When you're trying to save people's lives, you don't always have time to collect the data to document how you did that. But you're right, a very important part of risk communication are lifestyle factors. Some of the factors that we'll talk about later when we talk about health campaigns, because those are frequently targeted towards lifestyle factors. The focus that they're taking at this point with this group is dealing with this definition of risk communication. So risk communication refers to the real-time exchange of information, advice, and opinions between experts or officials and people who face a threat, hazard to their survival, health, or economic or social well-being. Its ultimate purpose is that everyone at risk is able to take informed decisions to mitigate the effects of the threat, hazard, such as a disease outbreak, and take protective and preventive action. So you can see that things like disease outbreaks and environmental crises, natural disasters are different than lifestyle choices, and require a different kind of approach. If I'm looking at smoking as a choice, that is, in some ways, a choice, even though we know it's a difficult choice. But that's not the same as being exposed to Ebola, or that's not the same as experiencing a volcano in my country. So this is kind of their working definition of a risk communication. They have then two key tracks or concerns, and they divided those of us who were on the panel into these two groups. Policy issues, so this deals with decision making and decision makers. We're not decision makers, right? We try to get on the ground and function as practitioners, applying our findings, but sometimes people will ask us for our opinions about policy, but not very frequently. How many of you have been consulted on policy issues? Yeah, me neither.
Corporate policy, not government policy.
That's right. Good. So they divided us into these two groups. And before I go on, I wanted some of your thoughts about the political concerns that you suspect would be encountered as this group, as the World Health Organization overall, tries to move forward in terms of addressing policy and policymakers. What comes to mind? Some speculation on your part. You've been following politics, probably a good portion of your life. You know how political politics are. What do you think?
Well, if you follow the Kyoto Protocol, or in general making statements about commitment to environmental issues, politicians are very happy to make statements, pledge in public.
Yeah.
Every country has done it.
Mm-hmm.
China and US did it. India did it 2 days ago.
Yes, absolutely.
But there's no action on the ground.
Mm-hmm.
So they will take it at the face value, but not do anything about it. And that's a bigger concern.
So it's all words. Good. It's all. I don't like to use the phrase "it's all rhetoric" because rhetoric really, those of us with a background in communication know, has a much broader meaning, and we don't want to use it just in the negative. Oh, that's just rhetoric sense. But it's words there. What else comes to mind?
I'm just showing you the different people involved, right? So if you're representing the government, your interest in the policy is very different than, say, you as an academic and your interest in that. So getting everybody to speak the same language. I mean, and I don't mean English, right? But really and in a way it is, right? And use the same words with the same meanings to be able to, first of all, communicate within the group of what you want to communicate externally. I can just imagine that's going to be quite a challenge because everybody's in there for a particular reason, right? Vested interest.
Good. So everyone's in there for a particular reason, vested interest, and with an agenda, and are willing to say the words and not follow through with actions. Good. What else? What else comes to mind?
There's this divide, and I'm again using WTO, my experience reading from WTO, all those meetings, is that certain regions will say this is a Western imperialist. WHO, World Health, or World Bank, IMF are all puppets of US.
Yes, all of
And so our concerns are different. Who are you to tell us what to do?
Absolutely.
So Europe against US, those kind of tensions exist.
Very important. Very important tensions. Yeah. Anything else you want to throw in the mix?
Well, the WHO I read about, recently how the way they respond to the Ebola crisis, and the problem was that all the regional politicians in the part of Africa that were affected, they want to get their mates in, their cronies in,
Absolutely.
in the key appointments, and they were based in the Democratic Republic of Congo. It wasn't really convenient. That's the main WHO center for Africa. And I think as a result of the crisis, they changed the kind of attitude, and the WHO headquarters, they just purged, those who were not supposed to be there. But very political.
Very
political appointments.
Right. So there's too much politics in policy making. Right.
Exactly.
Absolutely.
The wrong kind of politics.
The wrong kind of politics.
Crony politics.
Good. Excellent. All right. So you've got a handle on the difficulties that WHO is going to be encountering as they try to move ahead with this. So their identification of some important policy issues included things like, of course, leadership and governance. That's pretty fundamental. Financing. A lot of these things cost a lot of money, and there are not the finances available. Various information systems and technology. Some places in the world are well linked technologically, others not so much. And thus the communication of a person has come from this country and crossed the border into this country is very difficult, much more difficult than it would be to monitor in a country that's more technologically sophisticated. The human resources to deliver the health care, just enormous and very difficult. Doctors Without Borders can only treat so many people. There are other similar organizations, but there's such a small handful compared to all of the people who need to be treated. So human resources are, of course, a huge issue. Yes.
I wonder why there's no knowledge sharing in this policy issue, because I think it's the core issue of it's the knowledge.
Yes, and the people at the WHO absolutely agree with you. That's the impetus for this project, to generate the knowledge, to bring it together, and then to share it. They are exactly on board with where you think they should be going. So let's hope that. Do you use the cross your fingers for good luck? I don't. Here I am, 61 years old. I'm still crossing my fingers. I laugh at myself sometimes. I think that's kind of a juvenile thing to do, but I still do it. After all these years, I have it. I guess. And then, of course, tying in with human resources, the whole service delivery process. So many complexities on the policy issues. The key issues that they're focusing on in regard to practice are related to messages and stakeholders. So these are things about which we have expertise. And the committees includes, the panel includes policy makers who are really interesting people. I haven't spent a lot of time around policy makers in my life. I don't know if you, I have, not governmental policy makers. Very interesting. And then the people on the ground. So our primary concern are messages and stakeholders. And the kinds of things that they're interested in are very closely related to the work that many of you do. When the food insecurity issues, the immigrant issues, the migrant worker issues are so related to a lot of these kinds of things. Okay, trying to bring it all together. Then I don't remember exactly what I had in mind with these various groups, but I wanted to throw a picture in here. So the puzzle, trying to put all of the pieces together. They're trying to generate then, based upon a lengthy series of systematic reviews that are being commissioned. I think that somebody's actually being paid for these, because unless you have a job for which that's a part, if you work for Cochrane, for instance, where they commission these systematic reviews, and they do have someone from Cochrane who's on the expert panel and is guiding the research. So that's very useful. I was really encouraged when I saw that. So much of the research on which they will be building is qualitative. And many of you who are well-versed in qualitative research know doing systematic reviews of qualitative research is much more difficult than doing a meta-analysis of quantitative research. But there's very little rigorous quantitative research on which to build, because again, the people who are doing this are trying to save lives rather than trying to do research on it. So they're primarily relying on qualitative, systematic reviews. So these have been commissioned and are in progress now. They're looking then, in terms of best practice, the preparedness phrase. So the World Health Organization, any country, etc., always has to be prepared ahead of time for what should we do if there is an emergency. So this is on the emergency risk communication initial guidelines. That's a preparation phase. May or may not work once we get to the actual crisis, but we've got to start with these guidelines. This, of course, includes socioeconomic, political, cultural analysis. Again, many of you are experts in cultural differences in how we should enact health practices, health communication, etc. And know that there are no guidelines that will be one size fits all. So socioeconomic, political, cultural analysis has to be taken into account, as well as national and audience profiles. A lot of complexity there. So many of you are experts in some aspect of Asian culture, but there are probably things about your area of expertise that you would not translate to another Asian culture. You would know there are cultural differences that make a difference, and that have to be taken into account. So they're looking at, of course, best practices for the entire population from a broad perspective, various priority groups, and various high-risk groups. So some of you were telling me yesterday about the high-risk groups for the Haze. They're young children, elderly. I'm pretty sure I'm falling into that group now, so I'm going to use the mask that you gave me, and pregnant women. Anybody else falls into a high-risk group? Asthmatics, of course. There. So for any particular kind of crisis, there are high-risk groups. All right. They're looking at strategic communication, standard operating procedures. Great emphasis on translational communication. Talked just a tiny bit about this yesterday, but I'm confident that it's not a concept that is new to most of you. And as we think about translational communication in this context, two of our primary concerns are avoiding jargon, which we know is very difficult for us to do, and then analyzing fears and perceptions. For any kind of health problem, there are some unnecessary fears and inaccurate perceptions that affect how people respond to our health messages. I was on a dissertation committee, it must have been last spring, at North Carolina State, and the young woman was particularly interested in looking at diabetes and at inaccurate perceptions about the causes of the treatment of, etc., diabetes in the Latina community. So very focused, but boy did she come up with some interesting findings, things that I would never have thought about. It would never have occurred to me that people would have thought that such and such would cause diabetes, or that if you're not feeling bad, diabetes is no longer affecting you. She came up with interesting identification using some mixed methods of research, so some qualitative and some quantitative. Those fears and perceptions then are things that require some research on our part to identify, so that we can then address them, and they're not always easy to address. So, little cartoon, we need some new jargon. Public is starting to understand what we're talking about. Sometimes that applies to academics, I think, even more than politicians, but jargon is an important issue. All right, trust building is obviously an important part of all of this as you're trying to reach the people who may well be affected by the crisis, the risk that is coming. So for the trust building issue, which needs to be done during the preparedness phase as well as during the actual enactment phase, the dealing with the crisis, the sending out messages, etc. They're focusing on some things that will make sense to all of us. We'll say yes, these are good. Listening to the actual members of the community, finding out what those fears, misperceptions are. You notice down earlier. Down lower on the list, again, the notion of community engagement. Considering the type of work that most of you do, this notion of community engagement is not new to you. You know that this is essential for dealing with any kind of communication, certainly for any kind of health related issues. But turns out at the Ministry of Health Issues, they're not always so concerned about community engagement as we are. They don't see the value of listening to the people who are being affected by the problem. They don't see the value of finding out how the real people are talking about things, are thinking about things, are dealing with things, etc. And this became a particular problem with Ebola. I'm sure you remember many of the problems that you heard about in the media, etc. So part of trust building then, again, listening, early announcement. There have been numerous countries historically that tried to pretend a problem was not a problem. There probably are a few countries who have not, at some point, tried to avoid early announcement. But the data do seem to be pretty unequivocal that early announcement is much better than delayed announcement, even though early announcement is sometimes associated with increasing fear, etc. We always have to balance these issues. Consistent messages, and I suspect we can all think of some times when messages have not been consistent about various issues. And procedures for community engagement, I mentioned already. Making public any results of evaluations and reviews so that people know about those. Admitting mistakes and admitting unknowns. In so many of these crises, there are things we just don't know. And there are mistakes that we make. And the data, again, are pretty unequivocal that admitting that process is much more productive than trying to brush it under the rug. Is that a metaphor that you'd use here, brush it under the rug? My kids are always accusing me of making up these old statements, you know? I say, oh, no, it'll be something they haven't heard before. And I say, no, I'm not even creative enough to make up these old statements, but they constantly think I am. So glad you're familiar with those. And then, of course, developing and using skilled and credible spokespersons. So all fundamental parts of the trust building. Yes.
About the consistent messages. Well, sometimes inconsistency is a real part of the science. I mean,
It's true.
Well, it's not sometimes.
Yes.
At
The
least when
uncertainty.
it comes to non-communicable disease, it's been a part always.
Yes.
And how we can be consistent, because it's really damaged the trust.
Yes.
People keeping saying me that, oh, you will say something else in future. You know, you said something before, you scientists or you clinicians said something before, now you say something else. Sometimes I think it's the role of media that say something immature to the population, but that's a problem. We have a problem with trust building in that way. So how we can, and a part is the reality of the science. I mean,
Yes, it is.
you know, things change after the,
right.
you know, evidence accumulation of evidence. What can we do really?
The only suggestion that seems to kind of come out of the limited research that's available on this is to acknowledge the inconsistency. At least be consistent in saying, all right, we know that these early studies, and these early studies did lead us to believe such and such. We've built on that. We now recognize that such and such was a problem in this study. We've overcome that. And now the latest knowledge indicates such and such is true. Now, that still doesn't allow us to control the press, right? And the press many times is not well trained.
Exactly.
There are training programs available for them. So yesterday we talked about the one in Australia, training people about how to cover suicide. There are a lot more training programs about science communication. So encouraging journalistic participation in that is quite useful, but also being vociferous in our reaction to the press is important. I have one colleague, for instance, does really interesting research on organ donation issues, but over time he's been misquoted in the press, etc. So he refuses to talk anyway. Very productive way to handle it, right? As opposed to going back to the press, getting someone else for that press organization, for that newspaper, for that media outlet, and saying, no, this was wrong, and here's the additional information. Requires a lot of work on our part. We don't always have the time, but if we do, it can help both the press and the public learn a little bit about how science, medical science in our case, does indeed progress.
Yeah.
Do you have any other thoughts on how to handle that?
Actually, question whose role it is. Whose role? I mean, the scientists themselves
Right.
are producing the evidence,
Mm-hmm.
and that's a piece of evidence. You know, if my study showed something, it's not enough at all.
Uh-huh.
And if I am supposed to be a health communicator,
Uh-huh.
based on my study,
Uh-huh.
I perhaps, or even more probably, mislead the community by the message that is inherently immature. I mean, it's a danger always. It's there.
Right.
You can never get rid of that.
That's
So-
right. Mm-hmm.
And on the other hand, it's not easy to be a health communicator. I mean, it needs some skills that
Yes, it does.
we can't do communication with other scientists,
Mm-hmm.
and well, sometimes with other clinicians, medical doctors. But when it goes beyond to the community, I'm not very sure that I myself I'm qualified to do that. So whose role?
We don't, the medical communicator who was here yesterday, she's not here today, is she? Remember the woman, she was sitting right over there? Does anyone know her name?
Yeah, Bernie.
Okay,
She was medical writer.
medical writer,
Was
uh-huh.
different, a bit
Yes.
different from medical communicator.
Right.
Sometimes I thought that maybe it's the role, like we say that the systematic reviews.
Right?
Previously, we've been told that the systematic reviews should be written by old professor, somebody who is dominating the field, know quite everything. Actually, at the moment, it's not the case. Young people write the systematic reviews, and well, when it comes to the meta-analysis, it's not that important because it's more,
Straightforward.
Yeah, exactly,
Right.
something technical.
Yes.
But when you want to say something decisive about an issue, I guess that should be a role of somebody who's been in the field for a long time. He or she knows enough about everything, the last updated, not the each single scientist. But for example, I guess each health institute should have a department or at least an office for health communication.
Right,
What do you
right.
think?
I think that certainly makes sense, and many of them do have health PR offices. Now, some of these offices are much more PR-ish than others are, and their primary concern is making their health organization look good. Others do a very good job of representing research, data-based research, but at a level where maybe not the average person, but perhaps at least the average college-educated person. So pretty much on a daily basis, I get great emails from University of Pittsburgh about latest findings from some of their health research. And I know that they are sent out to make the University of Pittsburgh Medical Center look good, but they're presenting important data, and they're presenting it in a way that people can understand. So there are science communication writing programs, technical writing programs that are useful for journalists to go through, if we can get their organizations to allow them time to do that. But you're right. The process of generating the knowledge is not the same as the process of communicating the knowledge. But many of my students get jobs, for instance, working for hospitals or healthcare organizations, communicating that knowledge, sometimes through social media, since that is such a popular new outlet, sometimes to professional media, etc. But we need to do a lot more about that. Those are all excellent points. And hopefully the World Health Organization will deal with some of these. That is the goal. Okay, so we see the media there. The preparedness phrase also involves simulation exercises. You know, okay, we're encountering such and such a kind of crisis. What steps would we take? How would we handle this? What kinds of messages would we anticipate sending out, knowing that these will have to be reworded, readdressed, built upon, etc., in the future. So simulation exercises, and then after those simulations, after action reviews, what worked well? What didn't work well? Now we know simulations are always limited, but they're better than nothing. We at least get some practice at trying to deal with the crisis, and any lessons that we can learn from this about coordinating skills and our capacity to generate messages, to respond to relevant publics, etc. Hello. So this is still a part then of the preparedness phase. Also important, of course, is rapid assessment of stakeholders and audiences. And every health problem has different stakeholders and different audiences. There are some that we can identify ahead of time and know that, okay, if such and such occurs, then this group will be a stakeholder. If such and such occurs, this group will be a relevant audience to which we will need to reach out. Once we do that, then we start determining stakeholder group preferences, beliefs, practices, and traditions. Many of you have worked directly with specific cultural groups and are experts in the beliefs, perceptions, traditions that are part of this group. Your expertise then is invaluable as we begin to plan how to address these stakeholders and audiences. So some of it comes from experts like you, some from published studies or country profiles. Those provide a bit of data, sociological and anthropological research about various cultural groups, media, and social media monitoring. So much that we can learn now from monitoring, not quite so much what the mainstream media say, although we do need to start with that. We need to know what the mainstream media are saying about things. But think for a moment for me about the kinds of things that you could learn by monitoring social media as a, let's say, as an Ebola epidemic is beginning. What could you learn from monitoring social media? Some of you use social media a lot more than I do. So what comes to mind?
I think actually I know the doctor who is in New York City who got the Ebola from West Africa. I think that at that time the rumors or the news on social media attacking him to serve the community is like really a big problem.
Yes.
And then it makes the citizens in New York City so fear at that moment.
Right.
So they're so desperate and say that, oh no, we should not send any doctors to stop that one. But the point actually, if you don't tackle the source, it will bring a lot of problem.
Exactly.
So
Good.
I think that the social media play a very important role because at that time everyone go on Twitter, everyone go on Facebook and
There you
do
go.
those kind of messages sent out.
Yeah, and that's true with any kind of crisis, right? there is no crisis that's not addressed by social media. So rather than having to go out and do interviews and focus groups and surveys with people, we can now quickly find out what people's fears are, what their perceptions are, who they're blaming for what kind of messages we need to send to address those concerns. You all heard about the shooting at the community college in Oregon in the U.S. a couple of days ago. There was a journalist who was using Twitter as his primary source for reaching the victims. So he's, somewhere across the country, and he's reaching out, asking people who had been there, give me your story. He's reaching out to witnesses in that way. Now, he's been subjected to a lot of criticism, and appropriately so. There are a lot of ethical problems. But in some ways, it's just a variation of what we've always done, right? We used to go face to face to try to get witnesses. Now we don't have to do that. So while, again, there are some ethical problems, we can use those sources to gather data about how people are reacting to this Ebola incident, and thus how we need to address the audience. And that's true for any group that is technologically connected. And most people are. Daisy was telling me about the group that she's been studying in the Philippines. Very traditional in many ways, but they got cell phones. And they want to, and please correct me if I'm wrong about this, and while they want to maintain their traditions, they don't see using the cell phones as a violation of the traditions. They see the cell phones as an extension of the chants that they used to use to communicate things over a distance. Now, that's a fascinating finding. That's a finding that can be useful for us as we try to respond to crises and to various health issues. So there's a ton that we need to know about the kinds of messages that are sent over social media, etc. Yeah.
What was the ethical issue that you mentioned?
A violation of privacy is what some people were criticizing. I don't have a lot of detail. I just read about it on the Skim. Anybody else subscribe to the Skim? It's a very cool. I'm really much too old for it. But it gives me, the key stories of the day. That's how I keep up with what's going on in Afghanistan, with the Syrian crisis, etc. Very limited source, and I should have clicked on things to go deeper. But there were ethical concerns, So I've just been through a horrible experience. Is it fair that I got to get this tweet from this stranger who I don't even know, and he wants my story? What do you think? What do you think about that? Is that an ethical issue?
I think nowadays you can't stop, even it is.
Yeah.
Maybe a problem because there may be some not real stories coming out. Some people just want to make story.
True.
And then that would be very difficult to identify which are the real story.
Okay, so verification would be more difficult, right?
Yeah.
Right. Good.
And for that, they had to be in the field, really. You had to be in the ground.
Yeah, and also I think for the tweeters or those who use social medias, maybe they also have their own perspective or their own angle, their own interests.
True.
So it's kind of very difficult to identify, even it's a truth.
Sure.
But as a journalist or someone who do communicate this message out,
Right.
you need to be very, very careful.
So not just an ethical concern, but a validity concern. And as Julio said, there's no substitute for being in the field.
Yeah. And also tied up with the thing about early announcements or the lack of it.
Right.
Because sometimes, local authorities or whoever are in denial because they
Oh,
want to
yes.
avoid the panic. So unfortunately, the first they hear about is through Twitter and all that. So how would you address that? How do you address the concerns of an authority that they want to avoid early announcement because of panic and trying to bypass,
Excellent.
Yeah.
Excellent question, and that's one of the
Yeah.
things that the policy group, that that subset of the WHO panel is going to have to address. How can we convince people that that early announcements are better? Hopefully, some of the data that are being collected will help address that. We don't know at this point, but perhaps some of the people from various various health ministries will have some suggestions about that. These people are put on the expert panel because of their experience about it, because of things they have handled well, and let's hope that those kinds of people will have some suggestions about how to encourage politicians, policy makers, to make our early announcement, and perhaps noting that these are going to be covered on social media any way will have an impact. We certainly have seen over the last, 100 years, as the mass media have broadened, that politicians, etc., have recognized a need to acknowledge things earlier. Not always. Plenty of times when they still deny. But there have been more instances of more open communication and earlier announcements than there used to be. Before, the media were going to cover it anyway. Now, media are going to cover it anyway, more quickly through social media, not through media who are even taught anything about ethical guidelines, or journalists who are taught anything about that, but through us ordinary people. Now, really, in terms of communication about this, we're not ordinary people. We think a little bit more about these health communication issues, I would hope, anyway. But we know that the typical person communicating through social media is just passing on, just generating their own messages, which may or may not be accurate. But so then published studies, country profiles, etc. Feedback from first responders who are on the scene and those affected by the health crisis. And with social media, it's easier to gather such data now. And in some cases, we can go back to our reliance on focus group discussions of community leaders and representatives, local personnel, volunteers, etc. in a risk communication setting when the actual crisis is occurring. We don't always have time for focus groups, but in the preparedness phase, those focus groups can be useful for us. All right, moving on past that initial preparedness, but still in what we're calling the preparedness phase, is initial message development, testing, and revision. The notion of contextualizing and adapting pre-prepared messages is important. So most organizations, for instance, know that their public relations department is going to have to address certain kinds of crises at various times and have pre-prepared messages. We need to do that more with health issues. Pre-prepare, test, and revise those messages. Sometimes the messages, as we initially generate them, are not clear to the people on the ground, to the people who need to get that message. So our testing of that needs to then be followed by revision of those messages. We've got to prepare messages that can be delivered in a speedy and flexible way, and have to develop strategies for testing of new messages as they come to be needed in unanticipated ways, messages, materials, etc. All right. So that was kind of group number one from this expert panel, and the group number two focused more on the ground issues. That was the part that I was involved in, and the key, won't surprise any of you, the key theme for actually dealing with things on the ground was community engagement. Getting in conversation very quickly with the community leaders, with people who were affected by problems, and the first responders again that we mentioned. So themes, with our overriding theme of community engagement came issues of social mobilization, of the role of interpersonal communications. And I'm using the word as a noun in the plural because it's a pet peeve of mine when people say communications and they're talking about the process of communication there. But used as a noun in the plural, it is indeed acceptable. Just had to rant for a second there. Do you encounter that, like on your campus, people calling you the Department of Communications? There.
Officially we are.
Officially you are.
Yes. But we are having this debate recently about communication and communication.
All right. So you understand.
That's why Samir was because we as a department we're going through this crisis right now. Is it S or is it not an S? What does that communicate, right?
There you go. There you go. Yeah. And if we're talking about high-tech satellite communications, then the S is appropriate. Or if we're talking about a communication in the plural, those are the only two times when communications is acceptable. I've done research on this. Okay, so when you think about social mobilization, you think about getting the people who are involved together to act on this. So we will have pre-prepared procedures for doing that, but then actually have to get these people together. The people who are going to be making the announcements, the people who are going to be contacting those who could be exposed to the illness, the people who could be affected by the natural disaster, etc. And of course, in most communities, there are leaders and representatives who will be crucial here. These are people we need to identify ahead of time, but work with on the ground when the crisis actually occurs. We know the interrelationships between mediated communication and interpersonal communication. In any crisis, using both is essential. We can't ever rely, same with any health campaign. For instance, we can't ever rely just on mediated communication or just on interpersonal communication. The two work best together. Brian Sothwell has done some wonderful writing on this topic. I think really is kind of a leader in building this argument. Then those on the ground listening skills and tactics for getting in touch with people, back to trust a building by giving information as we have it, even if at some points we need to make clear that this information is limited, we don't know for sure, but at this point what seems to be occurring is such that's all a part of continuing the trust building process then. Now, using various mediated and mass communication channels, of course, expedites how quickly we can get information out. So the notions of including regional, national, international outlets are quite crucial. Social media communication, social mobilization, getting people in contact with each other. Now, in many cultures, there are locally relevant strategies that we can use. Town criers, for instance, as we're raising awareness about a particular issue, there are road shows, street drama that can get the information to people in a way that they are more comfortable accepting and will be more likely to respond to than they just will an announcement from their national ministry of health. Community radio, of course, and use of text messaging, a more specific type of social media. Now, as we think about stakeholder and partner communication, we're going back to the decision makers, those policy makers that we talked about before. So briefing various ministers and spokesperson, briefing the cabinet, etc., other government counterparts. All of these groups need to be involved. I've kind of been stressing the community, but that doesn't work without communication at this level. So again, national and local authorities and responders, NGOs, and various aspects of civil society. Professional associations can be quite useful. Medical associations, travel associations have ways of getting the a word out that the average health communicator might not have access to. Private sector counterparts who are perhaps leading employers in an area might be useful, and then one would hope the UN and international agencies and responders. So various issues related to stakeholder and partner communication. We close here with just a couple of pictures from Doctors Without Borders, taking care. Can you see that? All right, I probably should have lowered the lights before. But a doctor taking care of a little boy, someone in the middle of a crisis. I believe this one was an earthquake. That looks like earthquake damage, doesn't it? And another doctor taking care of a little guy. These are our goals. These are our ultimate goals. Taking care of people affected by various risks, crises, natural disasters, epidemics, etc. So the planning can't lead to an avoidance of a crisis. Crises are going to happen. Some crises can be affected by health campaigns, and we'll talk about that in a little while. But crises are going to happen, and taking care of people is our ultimate goal.